I'm Akiko Shimamura. I am a pediatric hematologist oncologist at Dana-Farber and Boston Children's Cancer and Blood Disorders Center and Harvard Medical School.
And I'm Phil Scheinberg, hematologist in São Paulo, Brazil, where we coordinate the hematology program in a big cancer center. And we had the pleasure to, with Akiko, develop the program for the non-transplant treatment modalities for severe aplastic anemia. And I thought, Akiko, it was a great session.
It was a terrific session with a lot of great discussion. It's an exciting time, I think, in the field for non-transplant therapies.
And we had 4 talks.
We had 4 talks, and we started out with acquired aplastic anemia, and then at the end we talked about some of the genetic bone marrow failure conditions.
So as far as the talks that we saw on the novel regimen for aplastic anemia, we had 2 talks that addressed that issue. Mm-hmm. One was the NIH trial with horse ATG cyclosporin L-trombopag long-term follow-up, which is obviously very important for doctors and patients to know what's happening 4, 5, 6 years down the road with novel therapies. And but the more recent European trial that looked at the comparison between horse ATG cyclosporin versus horse ATG cyclosporin L-trombopag, which were both positive in terms of the trials, both the NIH and the European trials. What was your take of this, the long-term data of the American NIH trial?
Yes, I thought it was very encouraging that we were seeing sort of sustained responses, but relapse still continues to be an issue that I think we're going to have to continue to consider. Clonal evolution data was encouraging that they were not seeing increased somatic mutation acquisition. And similarly for the randomized trial, they were also not seeing a high degree of somatic sort of clonal disease, but this still remains to be followed. It's still early days yet.
For the European trial, correct. The randomized trial, the follow-up is still relatively short, but still they haven't seen so far any significant cytogenetic clonal evolution differences. And I agree with you, the high-risk clonal evolution rate at the American trial, which has been a median follow-up of 4 years now, is still around 6%, which is not it's not a high number compared to what we have seen historically. It's very in line with what we have seen historically. And these are abnormalities that are associated with monosomy 7, complex cytogenetics, evolution to MDS. So 6% of those fall into that category with the ATG cyclosporin L-trombopag, which are 2 drugs that suppress the immune system and 1 drug that stimulates the bone marrow. So L-trombopag has been investigated for the last 10 years now, and we're starting to see long-term follow-up from the single-arm study of the NIH. And we're hoping to see long-term data also from the European trial. Now, there is an alternative TPO agonist also available, which were developed, both of these for ITP, actually, immune thrombocytopenia, which is a different disease, romiplastin. But this has been spearheaded by the Koreans and the Japanese, and they've been investigating this other TPO agonist in severe aplastic anemia and also non-severe aplastic anemia. What was your take of Shinji Nakao's presentation?
Yes, that was very encouraging data. Some of the data that is quite novel from Asia showing responses, very nice responses, in a significant subset of these patients. And there was some thought that perhaps the responses might even be better, but it's still early days, small numbers. And it did, as Phil mentioned, include very severe aplastic anemia as well as moderate. So, we have to be careful comparing different studies. Nonetheless, I think that this is really terrific pilot data to stimulate further studies.
And I think they were in second line, right? I don't think they had frontline data, although studies are ongoing, but I think he presented just second line refractory patients.
I think that's right. Yeah. For those who had received some L-trombopag.
Yeah, and also patients who had received immunosuppressive therapy.
Yeah.
And he showed some very interesting cases of patients who failed one agent and then responded to the other, and patients who failed immunosuppression. And so you're right; it's preliminary, but we have to see how this falls out in larger multi-center trials.
And I think the other interesting thing about this is the side effect profiles are not the same between eltrombopag and romiplastim, so this may offer, even if equivalent, alternative treatment options for some patients who are unable to tolerate eltrombopag.
Yeah, so the TPOs have really added activity and benefit to patients with aplastic anemia. Obviously, eltrombopag is the only one that's approved so far in the U.S. and in many countries. Now, we'll see romiplastim with this data becoming more mature. They'll probably also file for approval and registration in many countries. We'll see. It's very exciting times.
It is exciting. The other interesting observation, though more time is needed, is they did not observe any clonal disease with romiplastim so far, but it's early days yet.
Yeah, and we asked about that. There was a question in terms of the numbers looked really low, but they don't seem to see clonal disease in general in
It's
Japan
much lower,
and East
like
Asia.
5% is what
yeah,
he said, as
so
opposed to...
we'll have to see how this pans out in a different population. And the last talk was on not immune-acquired aplastic anemia, but a more hereditary forms of aplastic anemia, which are associated with telomeres. And this was a talk given by Rodrigo Calado, which discussed an intervention that actually benefits some of these patients. So what do you think, since you are a pediatrician and you're very interested in, your focus of interest is a lot in these telomere biology disorders, as in Fanconi anemia and others. What do you think of that presentation, and how do you think that adds to what we have today in terms of armamentarium for these patients, which unfortunately we don't have a lot to offer other than stem cell transplantation, but that's really also not that easy, can be very toxic and can lead to other complications.
Absolutely. So I think one of the big challenges with some of the genetic bone marrow failure conditions are the comorbidities that go along with that. These genetic conditions can affect not only the bone marrow, but other organ systems, which complicate then treatment. And as you mentioned, bone marrow transplant can be particularly toxic. And so alternative therapies are of high interest. And I think what was exciting was the data from Dr. Collado showed that with nandrolone, he saw an improvement in hematopoiesis, meaning blood count, blood production, but also saw improvement in other organ systems such as the lungs. And there is problems with sort of lung function and basically oxygenation in many of these patients, and that improved on nandrolone. So that was also very exciting, that this may treat not only the bone marrow failure, but perhaps some of the other organ systems that can run into trouble. And he showed very nice data showing lengthening of the telomeres, although the mechanism is still being elucidated there as to how that is occurring.
Yeah, the numbers were relatively small for the trial in general from the lung patients, but really patients with fibrosis and telomeropathies really have almost no options or very limited options. So anything is something that we latch on.
Absolutely. And it was a nice follow-up to the beautiful danazol study done by Danielle Townsley with Neil Young and the whole NIH group. So I think that this expands now sort of the armamentarium that one might consider for these patients, and you can choose in part based on the side effect profiles, I think, of these conditions, but these agents, but still I think that it's really promising data.
And that was the last talk of our session.
That was the last talk.
And I thought it was very exciting. I thought there was a lot of new information, unpublished data being discussed and presented. And we had throughout these presentations a lot of discussion about the data that was being presented. So I thought it was very interactive. It was very dynamic.
It was terrific. Phil, I wonder if you could share your thoughts on sort of future directions that came up to this session and what you see in the future for non-transplant therapies.
So I think the TPO strategy is one of interest, and that's being explored in different combinations with other agents, like rabbit ATG, for example, and Shinji Nakao talked a little bit about that in some countries where horse ATG is not available. There are alternative TPO agonists that are being explored. We talked about romiplastim, but there are others as well, and they are a little bit different in terms of a mechanism of action and potencies, and it'll be very interesting to see the results of these trials. And there are studies also looking at, especially for the older patient who is really not eligible for transplantation or more intense immunosuppression, to treat them with a combination of oral agents like cyclosporin and L-trombopag, or one day maybe cyclosporin and romplastin, and maybe androgens might be combined to that mix, and you might have an all-oral therapy addressing different aspects of this disease, like the immune system stimulating the bone marrow, and androgens doing a little bit elusive in terms of what they're doing. So I think that'll be interesting to see. This is what we discuss in our sessions. There are other interventions that are involving immunosuppression where are blocking some cytokines,
Yes.
like IL-2, to see if that has any benefit in patients with aplastic anemia. This is a trial ongoing, so we have no information and no data. And to prevent relapse, the NIH trial, sirolimus is actually, which is a drug that when we tested in combination with cyclosporin ATG really didn't do well, but maybe as a single agent later on to prevent relapse. Right now is 2 years, but you might make an argument that you may want to bring that forward to 6 months and then switch from cyclosporin to sirolimus, since it's more tolerized. It makes the cells more accepting of the immune system. So there's quite a bit of work ongoing.
Absolutely.
In the non-transplant field.
In the non-transplant field. And then I think that as pediatricians, for both of us, I just wanted to point out that from the NIH studies, they did a sub-analysis of the pediatric population and found that particularly for the younger children, that there was no added benefit to adding L-trombopag. So we have to be so careful in trying to extrapolate from data in adult studies for children.
That is true, and that was a lot discussed. There's a lot of discussion on that, and that's an important subgroup analysis. Obviously, it's not a trial just dedicated to pediatric patients, but it's a big trial. Has a lot, over almost 30 to 40 pediatric patients. And you're right, the benefit wasn't seen there when adding L-trombopag to standard immunosuppression. A bit unclear why that might be. Children tend to do better with immunosuppression in general. They might have more bone marrow reserve compared to an adult. We don't know. It's all speculative. But we got a lot of questions. A lot of pediatricians asked me about, should I add L-trombopag? And I said, well, based on the data, that's not something that should be done at least systematically or routinely, unless there's another reason why you might want to give it. But so that was a big part of what we discussed. Clearly, the benefit of the TPO agonist or the thrombopoietin receptor agonist, like L-trombopag, is far more in adults.
Yes, and I think that's an important point, and certainly an unmet need to study pediatrics, have pediatric-focused studies, in addition to the wonderful adult studies that we're seeing coming in.
Yep. So that was our session. I hope we were able to summarize and give you a little bit of a synopsis of what we discussed. It was a pleasure to be here in person and see a lot of colleagues. All of our session talks were in person, so that was great. And I really had a great time, Akiko.
Likewise. Thank you, Phil. A pleasure.
Thank you.